Good morning, everyone. Yeah, and Professor Waya and Professor Coordinator Dr. Aima, and also Ari, and also out of the college of Udayana University. I'm very happy to be here because I think sharing always is the most happier thing in the world. And I have no idea that at this time I would attend the meeting just like this kind. And I never been a meeting just like this appearance. But anyway, I have many experience. Have talked to about the thyroid, the minimal invasive procedure to a lot of people all over the world. But I need to say this is the first time I facing so many general surgeons because this is very, very advanced and a new technique. As I initial my topic is the game changer. Game changers mean is the no matter the key person, key measure, or key periods that would evolve the transition into a new version. And for our dear general surgeon, as we know that you work very hard, try to deal with the most challenging disease, especially for the thyroid. So I'm very happy that you have so much insurance would like to learn the new technique here. Today, I would like to first briefly overview of the thyroid IFA, including the indication and contraindication. And also, I would like to go through such as the treatment using this method, especially in the cancer. So maybe you will have a lot of questions. I think we have a lot of time, and I try to make sure that everyone understood how to do that and how to avoid the complication, and also what's the new development in the future. Next one. I come from the Kaohsiung. Now I take care of the thyroid head and neck operation center. Next one. Just as you know, I come from Kaohsiung. Kaohsiung is a south part of Taiwan, and the population is about 3 million people in this city. So, but I think the weather and the humidity is very similar to Indonesia. Next one. Now in my hospital is a medical system. So far, we have 7 or 8 branches in Taiwan, and Kaohsiung Chang Gung Memorial Hospital is the second biggest medical system within this whole system. And that's the Formosa Group founder, the Wang Yongqing. He is a very famous businessman in Taiwan. Next is this. Next, okay. And now the total capacity of my system is 10,000 bed. 10,000 bed. So it is a very big medical system in Taiwan. And for the Kaohsiung Chang Gung Memorial Hospital, so far, it is the third biggest medical center in Taiwan after the Linkou branches of the Chang Gung Memorial Hospital, and also another government hospital is the Taipei Veteran General Hospital. And this is my center. You can see the logo. Aria also have a picture in front of this. And this is the room I do the thermal operation for my patient. This is a very interesting paper because the radiography is the formal journal of the radiology. So you can take a look about the title. It is an invited commentary, so not everyone can submit a paper to this journal. So you can see the title over here is the thyroid ablation is ready for premium time. It is a formal journal. It's our best, one of the best journals. So you can see now the minimal invasive treatment of the thyroid become more popular. And you can take a look about especially the publication, including the microwave and the RFA. For the past few years, a very obvious increase of the publication. So it means that it draws a lot of attention to this new technique. And at least a lot of people have been treated by using the thermal ablation minimally. And basically, yesterday I have a talk in our ALTA that the first one is introduce this method, try to treat the symptomatic benign goiter. That's all the purpose, symptomatic and the benign goiter. This is a technique begin introduced by Korea, Dr. Bei, and also some region in Italy. But in Italy, initially used the laser, not the thermal ablation, such as the IFA or the microwave. And he have a lot of guidelines made by the Korea Society. So theoretically, that is a well-established technique, especially in Korea. And we also made a guideline from the ACTA. ACTA is the biggest tumor ablation society in Asia, and together with some doctors in South Asia and also Japan and Korea and Taiwan, we made a guideline to let everyone can follow the rule to treat the thyroid minimally. So far, you can see so many guidelines have been made in UK, Italy, also Taiwan and United States, Europe, Korea, of course. So maybe it already the time and it's a really mature technique that allow us to do some benefit to our patient. So that's the procedure, basic result before and after. I think now a lot of new techniques have been developed by our surgeon, especially from bilateral axilla, breast, nipple, or from the transoral. It's also a scalise. But anyway, most of them need to go for the general general anesthesia. And by using this method, most of the guidelines suggest local anesthesia is good enough. And theoretically, for the thyroid treatment, you need a team. Radiology is just only one of them. And in our daily practice, it's a little late. We need endocrinologists, surgeon, of course. Some procedure are performed by ENT or oncologist. And nuclear medicine is especially important, especially for some hyper and hypofunction and also the tumor. And of course, the radiologist. And the basic indication for the IFA is that we have a symptomatic goiter, especially the benign and have some clinical problem. So once the mass become very big, it would have caused some cosmetic problem, of course, and it will compress the trachea and also the esophagus. So that's the timing to treat by some method to reduce the mass. It is a little late. Can I use the mouse or something? Yeah. Anyway, I can continue. But so how can we guarantee that the nodule is benign? I think all of you are expert. So we have a lot of patients have thyroid nodule and would do repeating the aspiration to confirm it's benign. And we also have ultrasound pattern to make sure it's a low risk, moderate risk, or high risk of the thyroid nodule. But basically, if you want to do the thermal ablation for the thyroid, two time aspiration, even different time or different location of the mass to prove it is benign. The patient can accept the thermal ablation to treat, to reduce the mass. And some guidelines also suggest that if you have one aspiration and the ultrasound pattern is benign, such as cystic lesion or major cystic lesion or spongiform thyroid nodule, one aspiration is enough to fit the criteria to do the thermal ablation. And you might ask me that how big of the nodule that a patient can accept the thermal ablation. Theoretically, they have no guideline very strictly define the size of the nodule. But basically, if the nodule more than 2 or 3 centimeters, if the location is not that good, for example, very superficial, it will cause some cosmetic problem. But if it locate too deep, for example, very close to the trachea or esophagus, patient will feel discomfortable, especially swallowing or induce a cough. That moment is the timing for the thermal ablation. Of course, some patients might have very big goiter, but did not have any symptom at all. Okay. Yeah, for example, this is the benign lesion, benign looking lesion, cystic lesion with cosmetic, coma tail, or the spongiform. Next one, sorry. Please help me. Okay, it'll be easier. Where am I? Did it work? Just click. But where's my mouse? Oh, here. But it did not work. Oh, yeah, sure. Yeah. Maybe. Please back. Sorry about that. Oh, yeah. So the benign lesion, if the ultrasound pattern just like look, one time aspiration is good enough to make sure it's benign. Somebody might challenge you about that. Sometimes in your daily practice, you have so many times of aspiration and echoes just look good. But in the end, after the surgical resection, it turned out to be malignancy. Of course, I agree with that. But so far from the reference and also my own experience, if you have at least 2 times of aspiration, very, very few cases been reported after thermal ablation turned out into the malignancy. It did not mean the thermal ablation would make the tumor malignant transformation. It means that the initial diagnosis may be not so correct. And sometimes within the thyroid, it's not just only the big benign one, but also have some small malignant cancer within the same thyroid. So it's a totally different scenario. But anyway, if you have 2 times aspiration, confirm this as benign, it is a good candidate for the thermal ablation. And this slide just want to tell you that, how about the malignant cancer? This is the 88 guideline. 88 guidelines suggest that you can look at the red box over there. For some patients, if the traditional surgical resection, including lobectomy, thyroidectomy, neck dissection, or even repeated radioactive iodine therapy, if still they have the lymph node recurrent, you can use this minimum method to treat a recurrent cancer. The minimum method include not just only the thermal ablation, but also using alcohol injection. Currently, maybe just 3 or 4 years earlier, United States just accept the thermal ablation become one of the treatment for the lymph node metastasis. Before that, a lot of United States doctors doing alcohol injection to treat the lymph node metastasis. Okay, next. And for the cancer, yeah. Okay. And for the cancer, you may ask me another question is that sometimes the lymph node is a lot. Sometimes the mass recurrence is very big. So how good of the thermal ablation could do to treat those recurrent cancer? We separate into the curative purpose and the palliative purpose. There's no very restrict criteria, how big or how many lymph nodes that we can achieve curative. But I think you also understood that because you are a surgeon, they also have different mature status for the same procedure. So once you become more mature, of course, you have better performance to treat or to take the tumor out. So, but recently, the most concept is if the lymph node is not much, for example, 3 or 4, or the size of the lymph node is not big, for example, 2 centimeters, maybe we can achieve a curative purpose to treat the metastatic lymph node, especially the local control. But for some lesion that is too big, maybe thermal ablation is just one of the measures. Maybe you can combine with target therapy, radioiodine therapy, or external radiation, something like that, to achieve a palliative purpose. Next. Next. So I would like to introduce how to do the pre-procedure evaluation. Ultrasound, of course. The word is not so clear. Ultrasound is of course. And 2-time aspiration, of course. Then we should record their symptom because our patient would like to, you would like to know how good of your procedure. The other one is a cosmetic problem. You might recall that. And also you need some laboratory test. The first one is the breathing tendency. Some patients might use some anticoagulating medicine. The other one is the thyroid function. Although that we say that a minimal invasive procedure would not affect the thyroid function compared to surgical resection. But sometimes the quality of the thyroid of patient is not that good. For example, he or she have experienced some thyroiditis before, or she or he had autoimmune thyroiditis. Those are situations would impact the result of the thyroid function after the thermal operation too. So before the thermal operation, you need to make a discussion about to the patient. For example, the TSH level, usually maybe 1, but if the TSH level before the thermal operation is 3 or 4, maybe 2 extended operation will lead to hypofunction after the procedure. Next one. And that's the formula they use to calculate the volume of the mass, no matter the thyroid goiter or lymph node metastasis. Sometimes we need CT. Another question raised is that how big of the cancer or the nodule can be treated. Here I listed the intrathoracic extension. Basically, if for a complicated intrathoracic goiter, for example, grade 2 or grade 3, below the aortic arch, sometimes we need the combination with a general surgeon and cardiovascular surgeon together to remove the goiter. So the big goiter, if you do ultrasound and you cannot find out the button of the goiter, you should suspect that an intrathoracic extension and arrange a CT is necessary. Next. And also the thyroglobulin level, especially the washout for the cancer evaluation. All of us are experts in the treatment of thyroid cancer. Thyroid cancer, sometimes the lymph node metastasis, not all the lymph node is a cancer. Maybe just a part of them is cancer. So a lot of cytological report turn out to be negative because we cannot directly puncture the cell cluster, cancer cluster. By using the washout thyroglobulin level, you mean it aspirate the free from the nodule, then put into the test to evaluate the level, the thyroglobulin level. Usually, if the level is higher than the blood level, it should be original location for the secretion of the thyroglobulin level. And supposedly it should be a metastasis lymph node. The next one. And this is, I mentioned previously, but the evidence is weak and no conclusion is about using the anticoagulation agent. Those people use anticoagulation always associated with some cardiovascular event. So there's no consensus how many days earlier before the procedure you need to ask the patients to stop the medication because of the consequence of the stop of the medication is even more serious compared to the complication of thermal operation. So need to make some discussion, especially for the cardiovascular doctor, how long that we can stop the medicine. Next. And this list is a very important list is that, and most of the question might raise from this slides. First of all, you need to let the patient know the size, the goiter is not disappear after the thermal operation, not disappear, not like a lobectomy. It takes time to gradually decrease or decrease of the size. Usually it takes 6 months. The thermal effect for one session of IFA, usually take from 6 to 9 months. It means that after 9 months, the effect of thermal ablation would decrease. So the size of decrease would not so prominent. Maybe the most obvious size decrease within 3 months. So you need to let the patient know how can they expect it. The second one is how many times you need to, the patient should accept the thermal ablation. Basically, if the nodule is 3 or 4 centimeters, and you become skillful, for example, after 30 to 50 case experience, it quite can guarantee that you can get a acceptable result. For example, 70% volume reduction after one session of treatment. And I think 3 or 4 centimeter nodule is a possible nodule that you can get a good result. Otherwise, if the nodule is bigger than 4, or you are a beginner to do this procedure, maybe you can really more humble to explain to your patient. First, we do one session for you, and the volume will definitely decrease. But of course, there was some part that we did not really treat it. For example, the margin of the goiter very close to the trachea or the recurrent laryngeal nerve location. We would not like to make damage to them. So we're really more conservative and ablate the other part. But not a big problem because since it's a benign lesion, it already within the body so for a long time and for many years. So when should we carry out a second ablation? Maybe during the follow-up and the tumor regrows again. That would be the timing to do the second section thermal ablation. And so the third point is the regrowth of the lesion. And you also need to let your patient know, sometimes during the procedure, since it is a local anesthesia, so patient might feel a little pain. It depends on how good your local injection technique. And also some other complication, and maybe later we will introduce this. And I think another important issue, information you need to get is that, is there any operation the patient has accepted before? For example, you might have some patient have one side lobectomy, and the other side have new growth of goiter. Sometimes we know that even the patient voice is normal, but it did not mean the vocal cord did not make damage due to previous surgery. So you need to be very careful to evaluate and take the information before you have this thermal ablation, because one of the most serious complications of the thermal ablation also is the make damage to the recurrent laryngeal nerve. And yes, next one. So the cosmetic score, usually we have 4 scores from the no palpable mass or the most severe that you can very easy to identify a cosmetic problem from the patient. The next. For example, this is a 41-year-old female and very bulky mass. Next. This is an initial ultrasound picture previously. This one before treatment, right after the thermal ablation. After the thermal ablation, theoretically, it will become hypoechoic. So one important issue is that try to follow all your own patients by yourself, because due to this ugly picture, sometimes the doctor did not so familiar with the thermal ablation. My thinking about this is a malignant cancer. Next one. And it's 1 month later, you can see shrinkage of the mass. Next one. 3 months later, even smaller compared to before, and already achieved 70% volume reduction. So even after 3 months later, we still can see a bulky mass within the thyroid. So you need to let the patient, how can they expect it about result? It did not disappear. Next one. So this 6 months later, and the bulky compression or cosmetic problem is improved. Next one. This is the picture I show you. So you can see the reappearance of SCM muscle. Next one. We published the first paper IFA in Taiwan. Next one. And we also met together with other centers in Taiwan, and totally more than 100 cases within the past 4 years in Taiwan. And we guarantee that using this minimal invasive procedure, we can achieve a safety and efficacy result of this procedure for the treatment of benign goiter. Next one. And basically, we using a percutaneous local anesthesia that will advance the needle into the thyroid, and we ablate one part after the others, then complete all of the lesion. And next one, supposedly it should be a movie. Please play the movie. Stop there. Now we are doing the local anesthesia. I think maybe 20 or 30 years earlier, the general surgeon even that can use a local anesthesia to take the thyroid down. So most of the nerve for the thyroid is in front of the capsule. So if you can do very good local anesthesia or overcover the thyroid capsule, patient will feel no pain. And please pray. And we puncture the needle into the deepest part of the goiter. And further, further. Stop. Why we advance the needle into the deepest part? Because the echogenicity change after the region has been burned, it will become obliterated or underlying structure. So if you ablate it beginning in here, then you cannot see anything below. So you need to advance your needle into the deepest part, then start the procedure and please pray. And once you found the echogenicity changes, you will draw your needle to another part and withdraw it. Next slide. And next. So I think I have a lot of things need to tell, but I think I did not have that so many times. So when compared to the observation only, next. If the group is similar between two, no matter the function or the thyroid function or the cosmetic problem, next. There's no difference, next. And next. And for the thermal ablation group, you can see if in the control group, there's no difference before and after follow-up. And next. For the thermal ablation group, you can see obvious improvement of symptom, cosmetic, and the volume compared to the observation before and after. Next. And next. And there's no change of the thyroid function. And next. So you can expect it stop. If there is only observation, nothing changed by maybe also a little bit increase of size. But for the thermal ablation group, after 6 months follow-up, next. 80% of volume reduction can be expected. Next. That's my own result. Even after 4 months follow-up, it can continue slowly decrease of the size until 90% is expected. Next one. So this is a good serious study from previous retrospective published from Italy and also Korea. After the long-term follow-up, 70 to 90% volume reduction is expected. Next one. And how about the patient who already have unrelated lobectomy? I think we still can preserve the thyroid function of the patient, especially the new developed technique. A lot of people actually have thyroidectomy maybe 20 or 30 years earlier when they are very young. But now they have new goiter in the contralateral side. It depends on how big of the nodule. If the nodule is not that big, still we can preserve the thyroid function at the same time also reduce the mass. But if the mass is too big, maybe you can consider and make a discussion with the patient. Maybe we just do partial treatment of the goiter to avoid too much damage to the normal thyroid function. So next. So I would like to skip that. Next. So you can see the same technique. We can have a very good volume reduction. Next. And a symptomatic improvement and the preservation of thyroid function. And next. So even that previous has a lobectomy, it's still useful for the patient. Next one. This is the previous operation scar. You can see after operation, we can obviously decrease the size of the lesion. Next one. And how about bilateral? Of course, you can apply the same technique with multiple sections. So I would like to skip this slide. Next. There's a slide from Korea team. Next. You can see very good result with multiple section treatment. So it means we can achieve this kind of result, but not necessary. It depends on the different country, different hospital, different health insurance, and the economic level of the people. Next. I just want to tell you that the minimal invasive procedure, you can achieve this kind of result. Next. And next. So here I have some meta-analysis. You can see in average speaking, the volume reduction rate can be achieved more than 70% to 80 or 90%. In the beginning of the development this technique, the success of the one procedure is defined as a more than 50% volume reduction rate. But now I think with the development improvement of the technique, most of you can achieve a result just like this. Next one. And it's my own cases. After 3 times of thermal operation with preservation of the thyroid function, and this has a multiple nodular goiter bilaterally. So obviously improve the cosmetic problem. Next one. And how about the complication? This is a retrospective and this is a prospective. And 300 cases, 1,500 cases. And next one. Multiple center. In general speaking, you can talk to your patient that the complication may be lesser than 5%. Next one. And the majority of the complication, the first one is, of course, the voice changes. Follow some of the nodular rupture, hypothyroidism, brachial plexus injury. And of course, during the procedure, you might associate some hematoma. Patient may feel nervous, anxiety, and also pain, induce vomiting. And you would make some problems such as a skin burn. And for the most serious one, of course, is voice changes. So that's quite an advantage. We use a local anesthesia because using local anesthesia, you can continue communicate with your patient. If they have any sign change of the voice, you can stop the procedure. Because not like direct cutting of the recurrent laryngeal nerve. Most of the voice changes during the procedure it's because of the hip injury to the nerve. So just like a skin burn, initially you would have a burn and have a bubble in your head, but once it recovers, then the transmission of the signal of the nerve will come back. And usually it takes less than 3 months. Some of them it may be just a day or week. Sometimes a few of them will be longer than that. Of course, from my own experience and also the resident published, some of them would also experience permanent voice changes. So it depends on how alert you do the procedure about voice changes during the procedure. Next one. So far, I think after my talk, thermal ablation is the safe and efficacy of the method. And another quite common question being asked is that how and when would the lesion regrowth? From the reference, usually after 2 years follow-up. is a high incidence of the tumor regrowth. And compared to those with two sections, the regrowth rate would obviously lower. But of course, once with become better and better of your ablation skill, you can decrease the rate of the regrowth. Next one. Next one. The regrowth rate is defined as during follow-up, for example, 1 month, 3 months, and 6 months, and 1 year. And after 1 year, we found this is the smallest size of the nodule. And we had a recall, for example, 2 centimeters. And during follow-up, it become 3 centimeters. It means 50% increase of the volume. We define it as a regrowth of the nodule. So the regrowth rate is calculated by this definition. Next one. And in my hospital, the regrowth rate is only less than 4%. I think this is the best regrowth rate all over the world. Next one. This is our result, only 4%, and compared to other team, already higher. Next one. Another one is intrathoracic goiter. I think maybe a lot of you were challenging me with this technique to treat the intrathoracic goiter. Next one. By using tilting your probe, just like this, you still can abrade some part of the goiter if the goiter is not too deep. Next one. This is a really easier one, intrathoracic goiter. I think a lot of surgeons may challenge that for this kind of intrathoracic, I still can take it out. I totally agree with that. But some of the patients really hesitate to go for the surgical resection. Next one. So that's what we can do. The low density region is the area has been damaged by the thermal ablation. So you can see we still can do a lot of effort to try to alleviate the mass effect of the goiter. Next one. Next one. And my concept for treating intrathoracic goiter is that the patient have intrathoracic goiter. Of course, he can choose a surgical resection by all your experts over here. And if they think that the nodule is too deep, for example, you need combine not just only cervical, but also extracervical approach to remove the goiter. You can use a thermal ablation to do downstaging first, then you go for surgical resection, of course. Or if the patient will not accept surgical resection at all, you can apply single or multiple RFA to reduce the mass effect. Next one. So we published the first paper using thermal ablation to treat the intrathoracic goiter all over the world. Next one. And how about the cancer? We are talking about the cancer including recurrent and primary. And this is the most famous paper of mine published in 2015 in Radiology. Radiology is the best journal of the radiology field. So far, impact factor is 18. Next one. It applied a thermal ablation in tumor less than 2 centimeters compared to the surgical resection. And you can see after 4 to 5 years follow-up, there's no changes for the free survival. It did not mean that the thermal ablation is better than surgical resection, but it means maybe it can become an alternative method because thyroid cancer is a relative benign malignancy. Next one. And so in 2018, Korea Society revised the thermal ablation guideline. Next one. They say that if the patient has high surgical risk or who refuse a surgery, they can accept thermal ablation to treat a recurrent thyroid cancer. Next one. It is a strong recommendation. And for a curative purpose or palliative purpose. Next one. And how about the result using thermal ablation to treat? You may challenge that, of course, we found the lesion disappear maybe 3 or 6 months later. And how about the long-term follow-up? Here another paper, just a small series, but anyway, have longer follow-up, more than 5 years. And only a few of them showing regrowth of the region or lymph node. Next one. So you can see from the paper, the volume reduction rate is almost 100%, and 91% of them showing complete disappear. Next one. For example, this lymph node metastasis, very difficult and challenging location, I think, for all the general surgeon, because it's very difficult to approach this region. So for most instance, what can we do? Refer them to do the radioactive iodine therapy again, second time, third time, or fourth time. Next one. So we apply the thermal ablation. This is the clavicle. And this is before and after the thermal ablation. Very obvious shrinkage of the nodule. Next one. And you can see the CT before and after, complete disappear of the nodule. Next one. The patient have another one, also a very challenging location. Maybe you can ask the help of the cervical cardiovascular surgeon to use an endoscope to do this, but it's already far away from the approach point of view, the point. So next one. I also do CT guide thermal operation. Next one. Next one. Just like you checked it. Decrease of the enhancement. Next one. Very simple cases, but sometimes challenging because the lesion very close to the trachea, and using thermal ablation with local anesthesia, 3 months later, complete disappear of the metastatic lymph node. Next one. So we published this paper using thermal ablation to treat the metastatic lymph node with or without initial biochemical incomplete status. Next one. By using the thermal ablation, we can downstage then to even a very good result. Next one. But sometimes the location is very difficult and very challenging, especially in the thyroid bed. So just precaution that once you would like to apply the thermal ablation, the thyroid bed quite common to induce the voice changes. So need to be very careful. Next one. And this is published by Europe, Korea team about the lymph node and their association with the trachea. Different kind of the subgrouping with acute angle, right angle, obtuse angle, or direct trachea invasion. Next one. By using thermal ablation. Next one. If the lesion have, for example, obtuse angle, it means very serious attached to the trachea, the complete disappear rate would decrease. Next one. But anyway, we still can achieve some good result. Next one. For example, the lymph node metastasis very close to the trachea, almost a complete attached to the trachea, just like this. And next one. And if you can do well hydrodissection, this after treatment, almost all of them have been removed by the thermal ablation. And you can see renormalize the thyroglobulin level. Next one. Next one. Here we have another lesion, just like this. Just like this. So I think maybe later you can give me some comment about this kind of cases. You undergo surgical resection. Next one. Next one. You can see the result over here. Complete disappear of the metastatic lymph node and normalize the thyroglobulin level. Next one. Next one. Very close. Even we cannot find out the margin of the nodule and the trachea. But it also depends if you can do the hydrodissection to separate the trachea and the lymph node. If you can do that, you have a chance to do a rarely complete ablation. If not, maybe just partial treatment. Next one. And this is another case, 82 years old male with a skin metastasis of the PTC. And the general surgeon reset this lesion. Next one. But 6 months later, it regrows again. 2 different regions. Next one. So we apply the thermal ablation 3 months later, 6 months later. You can see the result. Next. And here's another cases. So far, this is the most challenging case of my life. Is that because the woman has so many thyroid surgical resection, and now she has a right side vocal cord palsy. Right side vocal cord palsy. And now we found that multiple lymph nodes just very close and attached to left side of the trachea. So no surgeon would like to do the surgical resection for her. So we use a thermal ablation very, very carefully. And next one. Next one. You can see 3 months later, I think not complete, but most of the lesion have been removed by the thermal ablation. Next one. So that's a concept now for the treatment of thermal cancer by using thermal ablation. We did not recommend you to do the thermal ablation to treat the undifferentiated cancer because it grows so fast, very, very fast. I have one terrible case, a very poor experience, is that I do thermal ablation for medullary thyroid cancer because rapid growth and obvious mass compression almost need to amputation by all the patients. So the oncologist asked me to do the thermal ablation. I do the thermal ablation for maybe 2 hours, something like that. And I think I do a good job. Then 2 weeks later, I go to the bedside to look at the patient. In the end, he's still intubation. And I saw an ugly wound in the skin. It means a tract seeding of the lesion. And I found that almost a complete regrowth of the mass. So now in the treatment of thyroid cancer, we typically treated the PTC only, well differentiated. We already talking about the recurrent cancer. Now I would like to move to the primary cancer. Maybe we can stop after I complete the primary cancer. Next one. This is the guideline. For the primary cancer, if the patient refuses surgery or who cannot undergo operation, still, the thermal ablation could do some benefit to the patient. Next one, especially the low-risk thyroid cancer. The low-risk cancer means the size of the nodule based on the criteria so far, ATA is the lesion lesser than 1 centimeter. But it's very tricky is that who define the size lesser than 1 centimeter is small. How about 1.1? And how about 0.9? Nobody know that. But anyway, the criteria is not like it. Next one. And the basic criteria is that before you do thermal ablation, try your best to identify any suspicious metastatic lymph node. If they have lymph node metastasis, you better suggest the patient go for the surgical resection. And next one. And for those patients, we need a safety margin. Safety margin has 2 meanings. One is the original location. For example, is the lesion very close to a trachea, dangerous triangle, vessel, something like that. That's the safety margin. The second one is that all the oncology surgeon would like to know is that we prefer have a safety margin after I reset it or I treat it. So another second meaning of the safety margin is if the thermal ablation can achieve a safety margin beyond the tumor. And next one. So for these kind of cases, very difficult to achieve a tumor safety margin. But anyway, now we also treat a lot of cancer just like this. And this one. So I think the best candidate is just like this. Small one, far away from the trachea, esophagus, and the major vessel. Next one. Next one. So here we have a lesion in the trachea close to the isthmus. 6 months later, 12 months later, complete disappear of the lesion after the thermal operation. Next one. Here another cases. 1 year later, complete disappear. Next one. Here another cases, PTMC. But since the patient and the family still very worried about the result of residual cancer after the thermal operation. So 1 month later, they go for the lobectomy. And this is the specimen, next one. And the pathology told us that we complete treat the cancer and no residual one have been found. And next one. So we published the first PTMC treatment was thyroid in Taiwan, just only few cases. But now in Korea, Taiwan, Vietnam, especially the mainland China, thousands of PTMC have been treated by using thermal ablation. Next one. And how about the parathyroid, hyperparathyroid? Next one. I think it's also very interesting. After the thermal operation, in the first day, especially the primary hyperparathyroid, only one, right immediately after the thermal operation, the IPTH level can return within the normal range. Sometimes you will get a little bit fluctuation because renormalize or the other parathyroid gland. But anyway, so far in my center, the parathyroid by using the thermal operation, the successful rate is 95%. I mean, renormalize the IPTH level and also the calcium level. Next one. Will slowly renormalize of the calcium level. Next one. We published the first paper using thermal operation of parathyroid in Taiwan, including the primary, secondary, and also the post-operation recurrent. Because I think you also know that if in the first time of the parathyroid resection, not necessarily always we will find all the parathyroid gland. And sometimes the ectopic one will lead to the regrowth or recurrent of the hyperparathyroidism. In that situation, maybe you would hesitate to go into because of the adhesion of the wound. So this time you can use a thermal operation to treat the recurrent parathyroid. The next one. The next one, I would like to skip that. Next one. The next one, I think the best strategy is to use the CT to localize the parathyroid. So now is the basic data from my center. The last data calculation is in this year's March. Now we have around 1,500 cases of benign. Some of them is parathyroid metastasis. We treat a lot of metastasis and the PTMC. Metastasis is patient, but most of them need more than 3 or 4 lesions. And also we do embolization to treat the bit goiter and also the parathyroid or hemangioma. Next one. Some doctor asked me that using thermal operation to treat parotid tumor. This is a Washington tumor. Washington tumor. I believe we are the first team over the world to using thermal operation to treat the parotid tumor. We choose a Washington tumor is that Washington tumor, theoretically the malignant rate is very low. Some experts over the world say that in his life, he never found a malignant Washington tumor. So I think just like a benign thyroid goiter is a very good candidate to using thermal operation to treat the benign tumor, the parotid, try to alleviate the symptom due to the mass. So that's the basic approach method. We from the parotid tail because in this region, there are not so many facial nerve in this region. So we advance our needle from this side into the nodule, just like this. This is the caudal, this is the cranial. So the major branch of the facial nerve should locate over here. So we're using this method to abrade our tumor. Next one. Next one. This is the cosmetic improvement. And from our result, no facial palsy. And after 1 year follow-up, 94% volume reduction. Next one. Next one. And our method has been cited by the review article. This article is talking about currently all the methods in the treatment of the parotid tumor. And in the last section, that including the minimal invasive method, including the thermal operation, into this review article. Next one. And our long-term follow-up. Next one. No recurrence after 2-year follow-up. Next one. And how about the pediatric? It's still a controversial issue because we know that the malignant rate is really higher in the children. Sometimes you will associate some gene mutation. So the well evaluation of the lesion before thermal operation is very important. Next one. This is an improvement after 1 section for the pediatric. The concept that I apply the thermal operation to the children is that before they really get mature, for example, after the teenagers, all the decisions made by their parents. So we have a lot of patients actually have accepted thyroidectomy when they are very young or in the children. So even that they would like to remove the thyroid, maybe we can let the decision after she become an adult. So I think the thermal ablation can treat the problem at this moment. Next one. And we published the second world paper, the first one in Taiwan, using thermal ablation treatment of pediatric. Next one. And this is for palliative treatment. Sometimes we were facing some terminal thyroid cancer, just like this. The quality of life would be not very good. And you have bleeding or ulceration of the skin. So we, with multiple discipline cooperation with the radiation oncology and hemorrhagia oncologists, we applied the IFA, target therapy, and also one section of transartery embolization. So we still can find a lot of new growth lesion, but anyway, the quality become better. What is the one? The next one. The next one. And how about the other head and neck cancer? Basically, I did not recommend, unless they're also in the terminal cases. Sometimes of the patient, because of repeated surgical resection, they need a lot of flap to reconstruct the face. But one of my patients, because the plastic surgeon cannot find the flap anymore, so they cannot reset the mass. So I go for the ablation for the patient. Next one. Just be careful. I do not recommend it because these are high malignancy of the cancer. The other one is very easy to induce carotid artery blowout because of the salivary. Once the cancer get necrosis, the salivary would go into the region very close to the carotid artery, and the nutrition vessel in the carotid artery wall will be damaged, so lead to the fracture of the vessel and lead to the carotid blowout. So for these cases, we do preventive embolization. We embolize the external carotid artery. Next. And do complete ablation of the lesion. Next one. Next one. And how about other benign lesion? This is a hemangioma. The ENT doctor followed these cases since the boy in the teenagers. But because of complicated of the lesion, you can see not only the superficial lesion, but also deep part into the masticator space. So it's very difficult to treat this benign lesion. We cannot treat them just like a malignant. We can treat them, take it all out, and leave a very ugly scar and a flap reconstruction. But it is a benign lesion. Next. So we usually using thermal ablation, one session, improve the cosmetic problem for this boy. Next one. Next one. This is another story. This is an infant, maybe just a 3 or 4 months infant. Very terrible story. His dad, they cannot find her dad, and her mom going to the jail because of drug addiction. So the society take care of this baby. Initial our planning is to keep observation for this hemangioma, because compared to the body, for the small body of the girl, it is very difficult to reset it and found a big flap to do reconstruction. It means that the girl never have a chance to wear the bikini when they go to the beach. So we keep observation, but in the end, a couple months later, it rapid growth of the hemangioma. So we applied a thermal ablation for this girl. Next time, next slide. This is initial appearance. The next one. One session of the ablation. We did not really cure the hemangioma. But anyway, hemangioma is a benign lesion. We just try to small the hemangioma and try to shrinkage it and decrease the progression of the lesion. And they're happy ending of this story because the girl in the end have been adopted by parents that are coming from Europe. So I think in the future, when the girl grow up, if she would like to treat this lesion, compared to the whole body, now she just only need a small wound to take it out. Next one. How about the disease? If anyone can tell me what is the disease? Yeah, correct. Very good. Coffee outlet spot. Next one. Next one. Next one. Principal neurofibroma. Principal neurofibroma. Very difficult to treat the disease because quite widespread, very bloody, and easy to get bleeding during the operation. Initially, we did not want to treat the cases, but when patients want to go to sleep, every evening, complain of the painful of the abdomen. So we do the operation for this girl. A very good result and a release of the pain. Next one. Next one. I would like to skip that. So I think the only issue is that the technique of the echo guide procedure is quite important. If you just only do echo guide puncture or aspiration, actually not a big deal. It will not carry out a big problem. But if you fire, it means you will make a big damage. So always identify the tip of your thermal ablation needle before you fire. Next one. Next one. Next one. So far, I'm the head of the director of the head neck ablation center. And next one. And now I have a training program. This is all the content in my center. You will be, we will deliver you, including the indication, guideline, basic technique, complication, and also the concept in the treatment of recurrent thyroid cancer, PTMC, or other head and neck cancer. Or you also have the chance to observe other tumor being ablated, such as a parotid gland or parathyroid gland. Next one. And this is the 1-week training program from Monday to Friday. Supposedly, you will see a lot of cases, more than 6 to 10. And this is the lecture we would like to deliver to you. And in the end, in the last day, we will issue you the certification. The next one. That is the volume, our center. Now, every year, we treat 300 to 400 cases by using thermal ablation. And every week or every month, you can see some of these cases. Next one. This is my email. If you got interested, you can contact with me via the QR code. Next. Thanks for your attention.
Okay, thank you for Professor Lin. In fact, you can sit, don't worry. So what an impressive lecture that are given to us from Professor Lin. So we already have a list of questions.